you decided to go into medicine?
I never did decide to go into medicine. My father had decided it for me. He was a pharmacist, a frustrated doctor. All his friends were doctor. Before I was born, it was decided that I would be a physician. And I never thought of being anything else other than a doctor.
Was it weird having that on your back the whole time?
It really didn't feel like it was on my back. I thought it was a fine thing. You know, when you're prenatally brainwashed, you don't have much burden with it.
Yeah. So overall, do you think it was the right choice for you?
Oh, I couldn't do anything else.
Yeah. That's great. So where did you attend medical school?
I went to Georgetown University, class of 1950. I was at my 50th reunion last year.
How was that?
It was great fun.
Yeah. Saw some old friends?
So a lot of the old friends still came back, yes.
Do you remember approximately what it cost to attend?
I know exactly what it cost. It cost almost doubled during my 4 years there. When we started, the tuition was $800 a year, and we graduated, it was $1,500.
So did you have to take out any loans or anything to help pay for your...
No, my father was able to get me through, and I didn't have to assume any personal loans. It doesn't sound like much, but in those days it was a bit of a sacrifice.
And how do you think that compares to the costs of today's medical education?
I think today's medical education costs more.
Yeah. Do you think that influences the choices young doctors make?
I told you my father couldn't go to medical school because he couldn't afford it, and I suspect that it may. I think it affects choices in a different way, though, not a matter of going to school, but of what they do when they graduate. And I don't think it's a good effect. I wish we could have less expensive or more subsidized tuitions in medical school and in residency training so that physicians could be financially free of making a decision based on making money.
So when you graduated, how did you come to choose your specialty?
Well, when I left, I took a rotating internship. My family was in New Jersey, and that was legally required to practice in New Jersey, where I had. But when I finished my internship, I decided to go into pathology, and was immediately taken into the Army and put into a psychiatric course and assigned as a psychiatrist. This got me interested in people rather than in laboratories and tissues. And I decided either internal medicine, which was always in the back of my mind, or psychiatry. And internal medicine at the time cured more people. Besides that, at the time, psychosomatic medicine was strongly in vogue, and I was very interested in that. And it could have been approached from both ways. And I decided the internal medicine way was the way I would do it. On the TV series MASH, well, I was Sidney, Major, I didn't get his last name, but who was always visiting Hawkeye, played poker with Hawkeye and the boys. I was consultant to a MASH in Korea, in psychiatry.
How was that like?
I hate to say it, war was terrible and the whole thing was awful, but I grew up, I learned a lot during my time in the Army. I had I thought there were good assignments, and I flourished, I think, in Korea.
So you did this during your residency training? Or?
I did that after my internship and before my residency.
Were you involved in battles, dealing with soldiers?
I was stationed on the MLR, that's the battle line, the main line of resistance, above the 38th parallel, where we subsequently settled the dividing line between North and South Korea. And I was fired upon, Piper Cub would come over every night at 9 o'clock, and a Chinese soldier would throw shells, artillery shells out, bed check Charlie. And I was active in the war. I was where the fighting was going on.
Was that difficult?
It's like playing cowboys and Indians. I kind of enjoyed the whole thing.
So then after that you did your residency training?
Yes.
And did you go for your residency training?
I had 3/4 of a year at St. Michael's Hospital in Newark because my cousin was the chief resident in medicine there. But my real training was at the Mayo Clinic in Rochester, Minnesota, where I spent 3 years in internal medicine and received a Master of Science degree in internal medicine from the University of Minnesota. They now have their own medical school and are no longer associated with the University of Minnesota.
And after that, you decided to come back to the Worcester area? Or?
Not come back. I'd never been in Worcester. I came to Worcester. I was attracted by the Fallon Clinic, a group practice, specifically by the 4 doctors who made up the group. I wanted to go into group practice. I had no money at the time. I had a very tiny debt of about maybe $2,000, which today is nothing. In those days, it was on my back. And I wanted to go into a group practice, work for salary. I was going to see the Keene Clinic in Keene, New Hampshire. But a friend of mine told me about the Fallon Clinic, a 4-man group. And I came and stopped, and I was just fascinated by the doctors at the Fallon Clinic, who were as smart, as well up to date on the literature as these nationally famous doctors I was working with at the Mayo Clinic. I was very impressed with the group. And I became the 5th doctor at the Fallon Clinic at the time.
And how long did you stay there in practice?
All my life.
That's great. So, what made you decide to stay in this area? Was anything?
I liked Worcester. I liked New England. What made me I never got to Keene, New Hampshire, because we got here late one afternoon and had a broiled live lobster for dinner at a local restaurant, which I had never had before. And I decided Worcester was a good place.
Was there anything in particular that kept you in Worcester all those years?
I raised the family and had developed friends and became part of the community.
So I'd imagine you've seen a lot of changes in Worcester over the years.
Yes, a lot of changes. Initially, no. Initially, Worcester was bogged down, but it has progressed tremendously with the downtown buildings, the malls around Worcester. All of that has been since I've been here.
And how is your patient population? How did they change throughout the years of practicing?
Well, internal medicine changed tremendously during the years of my lifetime here. And so the patients changed. Initially, there were 13 board-certified internists in Worcester when I came here, well, not including me, so there must have been 12 when I came here. And we were consultants. I often had cardiology, hematology, almost one of everything coming in from Webster, far away as Athol, from northern Connecticut, even southern New Hampshire. We did a fair consulting practice, but in addition, a primary internal medicine practice too. And that, of course, is impossible for a general internist nowadays.
And did you see a change in the needs of the population of Worcester as you were practicing?
Well, disease patterns are always changing, of course, and in that sense, a change in the needs.
So it seems like you saw a very diverse patient population while you were here.
Oh, very diverse. I saw one of everything. With my Italian name, I saw a lot of priests and sisters. This was before anyone had insurance. I had a significant practice among them. And I also had a significant practice among doctors' families. I was the smart new doctor in town in the days when there weren't many of them, unlike now, when all of them are. And my initial practice was largely that. By the time I retired, it was literally a general practice. While we're collecting anecdotes, I had a boom in black patients at one time. I went out to the Martin Luther King dinner at the country club, Pleasant Valley. And during the course of the dinner, an elderly black lady at the table next to me fainted. And I got up to make it look good, and she had no pulse. She was dead. I went ahead with CPR, and she came around. I could feel, a little frail elderly lady, I could feel her ribs cracking as I was administering. In those days, you started with a punch. and her heart came around, an ambulance came, she went to the city hospital and left the hospital, was really coming back from the dead. And every black in town became my patient after that.
I can imagine. I think I'd become your patient if I was sitting there as well. That must have felt pretty good.
That did. That was, you're going to ask me about fond memories. That was one of my fondest memories. I became friends with some of the people who became my patients, too.
Yeah.
And very nice, wonderful people.
Yeah. So it seems like you were involved in ethnic activities around Worcester as well, going to Martin Luther King Day.
To some degree. I've never been an activist in anything, but I had always been a liberal in all my ideas. And people are people, you know, for heaven's sakes. I didn't have the problem of being prejudiced against anybody.
So I was wondering if you could describe a typical workday when you first started practicing.
When I first started practicing, I'd start out at the hospital, at St. Vincent Hospital, at 8 o'clock in the morning, make rounds on my hospitalized patients, and then maybe have a cup of coffee with one or two other doctors at, say, 9:30 or 10 o'clock, and get back to the Fallon Clinic where my office was by 10:30, where I started seeing patients. And I would see patients from 10:30 through the afternoon, maybe 5:30, something like that, during the day. That was a typical day's work. I occasionally made a house call, 3 or 4 a week. I don't think any more than that. And I occasionally was called down to the hospital in Webster or up at Clinton to see a patient, maybe once or twice a month at the most. But by and large, most of my day was either at the hospital or at the clinic. I almost always was able to get home for dinner, and occasionally 2 or 3 nights a week I went back to the hospital where I had an especially sick patient.
Did that change at all? Did your hours change at all as?
Oh, my hours did change tremendously. I have many fewer patients in the hospital at the end of my career, spent more time at the clinic, and more hours, actually. I was never finished before 6 or 6:30. I put in actually more hours at the end of my career than at the beginning of it. And the consultations, of course, fell off to almost nothing.
And when did you finish practicing medicine?
I retired from the Fallon Clinic in 1990, more than 10 years ago, but I then went to work at St. Vincent Hospital as coordinator of the geriatrics teaching program. And I finally retired completely in early 1999. My wife was terminally ill at the time, and I gave up practice to take care of her.
I'm sorry to hear that.
I very much regret leaving practice. I wish I were still able to practice.
Yeah. So you did have a family as you...
We've raised 6 children in Worcester.
How was that like with the pretty difficult
Well,
schedules?
of the 6 children, 5 were boys. In our house, the dinner time conversation was almost always sports. They were all athletic, most of them. One wasn't, but 4 of them were athletically inclined. 1 or 2 of them very gifted athletes. And sports was our way of life around here.
So it seems like you got to spend a reasonable amount of time with your family?
As I said, I was home for dinner almost every night, even when I had to go out afterwards. And I not as much time, of course, as if I were not a physician, but I think a reasonable amount of time. The kids all turned out great. They are now fine, upstanding citizens of the community. One of my sons died at age 39 of non-Hodgkin's lymphoma.
Were you able to take vacations through the beginning part?
Yeah, I always did. When I first started practice, there were the 5 doctors there. 3 of us were internists, and we did not have a coverage system. We were always on call. But if I were going in to see the Red Sox play, I would sign out to Dr. Myers, or if he were going someplace, he would call me and tell me I'll be away for the evening. But we always did take 2 weeks off in the summer at the beginning of my practice. I never missed it. And in fact, back in the late 1980s, after being in practice for almost 40 years, well, for more than 30 years. I finally took a 3-week vacation one summer. That was the longest vacation I had while I was practicing medicine.
Yeah. So you must have seen a lot of technological innovations
Oh.
over the years.
You would hardly recognize medicine from the 1950s to the 1990s. Many technological innovations. Imaging procedures are vastly different now than what they were then. If you had someone with gallbladder disease, you would do a Graham cold test, administer a dye and see it concentrate or fail to visualize in the gallbladder. The most difficult diagnosis in all of medicine was carcinoma of the pancreas. And you couldn't diagnose it without opening an abdomen surgically. Nowadays, it's a pushover. The imaging procedures have made a tremendous difference. Cardiac surgery was just beginning when I started practice, and look at it now. Coronary artery surgery consisted of poudrage, putting powder in the pericardium to entice fibrosis and adhesions. Even at that time, they used to take an internal mammary artery and make a tunnel in the myocardium and just push the internal mammary artery into it. But that was just barely beginning. The heart and lung machine was just coming out at that time. They did finger commissurotomies, closed commissurotomies for mitral valve disease. Rheumatic heart disease used to be very common. Every big family in New England had someone with rheumatic heart disease in it. And now it's a rarity. Acute rheumatic fever, I haven't seen a case in 20 years.
So you would say one of the biggest technological innovations was probably new imaging?
It's probably,
Imaging?
yes, imaging and surgical advances and all the pharmacological advances. The cancer chemotherapy consisted of nitrogen mustard, period, when I started practice, and nothing else.
Did you find it difficult to keep on top of all the new advances in medicine?
I've always been a scholar, and I loved being in the library, and I worked hard at it. I had no trouble amassing my required CME hours.
Yeah. So you mentioned one of your fond memories that occurred in the past while you were practicing. Would you have any others that you'd like to share with us?
You know, everyone who's practiced medicine for well over 40 years has got fond memories, and I have many of them. Okay, another one I'll tell you. A year or two ago, the Mass Medical Society had an essay contest of my most interesting patient, and I have a fond memory of my most interesting patient. I never submitted the essay to it. Had a patient who was a brother in a Roman Catholic order up in Barre, Massachusetts, and he came in because of edema. I quickly made the diagnosis of nephrotic syndrome, put him in the hospital, put him on steroids, and he did not improve at all. It was steroid-resistant nephrotic syndrome. And he came in to me and said, "You got to cure me." I said, "Well, you know, we've done everything that we know how to do nowadays." He said, "If you don't cure me, I'm going to lose my soul." I said, "What are you talking about?" He said, "Well, I've only been in the order for a few months," which I didn't know. He's a middle-aged man. He said, "I'll have to go back to my old job playing a piano in a whorehouse in Philadelphia, and I will surely go back to drugs and leading a wild life." And what can you do? The very next day came a notice from the National Institutes of Health that they had an experimental way of treating steroid-resistant nephrotic syndrome. I called them up and sent them down there. They were using, I think it was methotrexate. It was something that we use for malignancy nowadays. They accepted them into the program, and they had 50 people in the program. 49 were failures, and my patient got a cure. And he came back happy and remained well and became the director of music for the entire order.
Wow.
That's close to a miracle, I think.
Yeah, it's a good story.
I have many fond memories, and I'd love to talk about them, but I think we've had a couple of good ones.
Yeah. How about not so fond memories?
Well, I have some not so fond memories that I just won't talk about, things that I did wrong and that I still feel bad about many years later. Losing patients is always difficult. You never get used to that. As long as you're in medicine, you're still going to feel bad. When even a patient with hopeless malignancy dies, you're still going to feel bad. And the young ones who have a sudden myocardial infarction or something, you're going to feel bad. Those are my not fondest memories.
And you were involved quite a bit with the Medical Society.
Yes, I was. I was president one year.
I was wondering if you could tell us a little bit about your involvement.
Well, I first started practice in April 1957, and the annual meeting of the Medical Society was in May of 1957. So one of the first times I had to meet other doctors was at the Worcester District Medical Society's annual meeting. I quickly became a member and have been a member ever since. Everything I do I take seriously, and I took that seriously. I've been on several committees and worked for the society as much as I could without interfering with my practice. As I said, I was president one year. I was president almost by accident. John Howe was president and was elected president for the second time. He was the first person in the 20th century to have served 2 years rather than 1 year. And during his second year, John was offered the position of president of the University of Texas in Houston, and he couldn't refuse it. He went down there, which left no one coming up. The man, we had a hierarchy of orders. The man coming up was a pathologist who pricked his finger doing an autopsy on someone with hepatitis B, developed a fulminant hepatitis and died. That left the position open, and John had had it for 2 years and was on his way out of town anyway, so the society nominated me and I was elected as president. Otherwise, it would have been a few years later before they finally got around to me, I think.
Did any changes occur in those years that you were president of the Medical Society?
Some of the important things when I was president is WASOC was inaugurated, and I dealt with them. This was the Worcester area study for health plans, essentially HMOs, and that was originated then, and we worked with them, and they studied and developed a lot of information about prepaid health care. And actually, Worcester became, and still is, quite prominent in the HMO field. And I feel I contributed to that to some degree, at least. Also, there was an economic recession at about that time, and we provided free health care to people. The Medical Society decided to do that to people who had no insurance and were unemployed because of the recession. I think those were two important events during my presidency.
Did the Medical Society pay for the health care, or did physicians give their time to provide the care?
Actually, we had a list of names, and a patient called, said, I haven't got a doctor and I've got this terrible headache or something. We'd give them a name from the list, and the patient would go to your office and be provided, not anonymous, but he would be anonymous. It wouldn't be known that he was not getting a bill. And we had most of the societies signed up to support that.
So you've, I'm sure, seen quite a few changes in managed care and how things have gone over the years since you were in Fallon when they were only a 4 or 5 person operation.
Right. Well, we were pioneers with the HMO. In fact, Dr. Myers, who at the time was medical director of the Fallon Clinic, testified before the Rogers-Roy Committee in Congress to the establishment of the HMO law in 1974 or 1975. And I went to Washington with him and was present at the creation, as a matter of fact, of HMOs. There had been one, the Harvard Health Plan had started on their own without legislation and were winging it. And we were the second when the Fallon Clinic was the second HMO in Massachusetts. But with legal sanctification.
Was it difficult to initiate things with the HMO?
Oh, sure, of course it was. We had all kinds of just being in group practice, you had opposition. When I started practice, we were the only group, and we were actually, not initially, we weren't looked on as threats, and we had many references from the local family practitioners, many patients referred for consultation. But as we grew, as the clinic grew and got to be 8, 9, 10 doctors, we were looked on as a threat. And that the HMO was equally a threat. Dr. Myers, who always did things properly, came to the medical society and presented all our plans. So the medical society, and that means all the doctors in the area, were informed of how we were doing it. We did it with the help of Blue Cross and Blue Shield, who sent down representatives. We had innumerable meetings. A good part of my evenings were taken up at that time with setting up the plan. Took us a couple of years to get rolling.
So you said that some people looked at you as a threat?
Yes.
Who exactly looked at you as a threat?
Independent solo practitioners, and I certainly understand their view. If you signed with the HMO, you couldn't be their patient, and they felt that they would lose patients, and it would be an economic hardship to them if they were a successful HMO. Same thing with the medical school, you know, many highly independent solo practitioners opposed it, very vociferously opposed founding the medical school, because this was looked on as a threat to their practice.
As far as the HMOs go, what was the medical society's view on initiating them?
The official view was initially tolerant, and then as it grew, the society became a little bit more supportive, and in fact started their own HMO in a sense. The Central Mass Healthcare Plan was a society-sponsored plan.
Do you have any feelings on how HMOs have progressed throughout the years?
Oh, they've grown like wildflowers, the HMOs, and now are an important part of medicine in Worcester. In fact, I have a friend who answers his phone. This is so-and-so. And this is on the telephone. As before he knows to whom he's talking, he says, one of the dying breed of independent physicians.
That's true. So do you think it changed for the better, for the worse, a little bit of both?
I'm sentimental, and I think a little bit for the worse, but I think it's an inevitable change. I think the cost of medical care has become more than independent people can afford, and it's a necessary change. I don't know what that is.
Yeah. Strange noise. How did socialized medicine come into conflict with the advent of HMOs, or the thought of trying to implement a socialized healthcare system? Did they ever come into direct conflict?
Well, we don't have socialized medicine, really. We have, the government has taken a much, much greater role in the practice of medicine. Medicare and Medicaid are very significant factors in any practice. Today's paper mentioned the trouble that the medical school and Memorial are in because of inadequate payment for Medicare and Medicaid. They really supported a good bit of medical practice for a number of years. So the government's role is extremely important now. But still, the government doesn't pay doctors. Government, at least in name, does not interfere with medical practice. The doctor still makes the judgments.
So to switch gears a little bit, you wrote a book, The Community of Physicians.
Yes.
And you wrote it around 1995?
Yes, 94 or 90, yeah, in the early 90s. Yeah.
Among other things, what you talk about in there is the advent of the medical school here in Worcester.
Right.
I was wondering if you could just maybe give us a quick summary of that. I found it interesting in being a student.
Sure. If not me, someone else will tell you the anecdote of how it came to be in Worcester. But the state of Massachusetts decided there was an acute shortage of physicians at the time, actually as much maldistribution as well as shortage in numbers. But there was a great problem with finding a doctor in those days. And the state decided to set up a medical school. And a number of sites were proposed, including Amherst, which was the leading candidate where the university was. And it would be a real university hospital in a university town, affiliated with the undergraduate school and other schools. The Cape was a location. Boston was a location. Worcester was a location that was being considered. Boston quickly opted out. It was felt that it would be competition for the existing schools in Boston, and the existing schools all opposed Boston and mostly supported Amherst. And the Cape was eliminated as not having the clinical material accessible or the contact with the academic world accessible in the Cape, a little bit isolated. And one or two other areas were dropped because of that, left it down to between Worcester and Amherst. The trustees voted. Two of the trustees, I think there were 11 trustees, two of the trustees were from Worcester, and of course voted for Worcester, were strongly in favor of it. And after eliminating all the other sites, it got down to a tie. It must have been 12 people, but whatever the number was, it was a tie between Worcester and Amherst. And they broke before they took the final vote. And one of the Worcester people got talking to one of the other trustees, and said, I guess you're going to vote for, now that your town is out, you're going to vote for Amherst. The man said, yeah, I am. I'm a little bit reluctant. They refused my son admission or something like that. He had a minor personal grievance against me. So our man, his name was McGinnis, said, look, why don't you vote for Worcester? We got a great place. So he did. And by that narrow margin, by the single vote change, Worcester was awarded the medical school. It took a number of years for it to really be developed. A dean was appointed, Dr. Lamar Suter, whose portrait I am sitting under. He came to Worcester, spread goodwill among the Worcester community. As I mentioned, there was some hostility to it, but managed to spread goodwill and was successful in starting the school. Started at the old Shaw Tobacco. Do you know this?
No.
Out on Belmont Street, the Shaw Tobacco building, and that's where the initial school building was while they were building the current school building. Small class initially, a very good class, all of whom are still, I think, in some way devoted to the school.
And did you have any involvement at all with the medical school here?
I was a supporter. I was young enough to think that I would get a great deal of benefit from it. I would learn a lot of medicine, maybe beyond the faculty. And I was indeed appointed an assistant professor immediately. And I had some involvement. I was on the library committee, responsible for setting up the room in which we are now, and responsible for getting the Medical Society to intershelve their library's books with these, with the ones that Dr. Suter purchased from, actually from a library, medical library in Pittsburgh, Pennsylvania. So yes, I was involved with the school. We had clerks rotating at St. Vincent Hospital. We always had one or two or even three clerks on a round team.
So were you involved in an academic? You took residence on in the years that you were practicing?
Yes, yes, and I enjoyed teaching, partly because I learned so much.
They always keep you on your feet.
Yeah.
Asking you questions and stuff. Now, I can't think of any other questions that I'd like to ask you about your book, but I was wondering if there's anything that you could think of that you would like to share.
About the book?
Yeah, there's an awful lot of information in there.
Okay.
I think it'd really be nice to talk about it.
Dr. Paul Bergen, who is an obstetrician, perhaps the leading obstetrician in Worcester, chief of obstetrics, both at City Hospital, which is now defunct, and at St. Vincent Hospital, wrote a history, interested in history, and wrote a history of the society, which was never published. It was in typescript. And I edited it, and the society published it in book form. And this stimulated me with a couple of other people prodding me to bring it up to date. Dr. Bergen wrote it through 1954. The society was founded in 1794, which makes it the second oldest medical society in existence in America. There's a competition. New Jersey says they're older, but they were not continuous. Their society disbanded for a dozen years and then reformed. So I think that we still have the POM as number 2. And I brought it up to date from 54 to 94, which was the 200th anniversary of the Medical Society.
So now you're going to start finding somebody to take it over?
The book ends with a plea for someone in the future. Maybe you could do it, Paul.
I'm not a great writer, but we'll see. Maybe.
Oh, Dr. Bergen and I aren't great writers either.
So now we have a full transcribed history of the Medical Society since 1794.
Right, colored by Dr. Bergen's prejudices and by my prejudices. Mine is largely from my memory. I became a member of the Society in 57, and of course saw almost all of that 40 years that I wrote about.
Covered. You could cover a lot.
One of the questions that you asked me to consider beforehand is, what advice would you give to a young doctor? And I have advice. I don't expect it to get out to the young doctors, because I can't imagine a young doctor seeing this tape or seeing a transcript of it. But I would advise a young doctor to remember why they're doctors and to think about the patient first. Don't let your decisions be affected in any way by finances, insurance companies, HMOs, people who are doing peer review. Do what's best for the patient all the time. I think that's an absolute essential and something that every doctor ought to have in his heart.
Do you think that's advice that's been more difficult to follow since?
I never had any trouble with it. I would never listen to anyone who tried to pressure me into discharging a patient from the hospital a day early or something of that sort. I feel that to do this, you've got to know what you're doing and have good reasons for what you're doing. But if you do, you should never let anyone influence your practice of medicine or your decisions. When we spoke about government before, we spoke about how they nominally do not interfere with a physician's decisions. In a way they do, but not directly. For example, my favorite example is the nursing home practice. Physicians should be able to do anything they want and make any decision. There are a number of both state and federal regulations about you can't prescribe certain drugs under certain circumstances. And like all general rules, there are some exceptions that ought to be made. And if you followed slavishly just what the state or the federal government told you to suggested to be prescribed, sometimes you would be doing a disservice to your patients. And they can't make you not do what you want to do and prescribe what you think is right. The way they manipulate that is by telling the nursing home, okay, we're going to cut off your Medicaid sources. You're going to get less money or no money. And to that degree, they can influence it. So the nursing home administrator says to you, listen, so-and-so is getting a medicine that costs too much. Why don't you prescribe something else? But you don't have to do that. You should be able to do what you want to do. Not necessarily what you want to do, but what you know is best for the patient. And I think, no, if you really do it and know what you're doing, I think no one can criticize you for it.
Yeah, you hear a lot of that nowadays, so a lot of people having issues with getting...
A lot of the public perceive doctors' decisions as being made by other people. And I suppose to some extent they may be, but I think the doctor is at fault to let anyone else influence his judgment.
And I think finances do play a key role in some decisions, unfortunately. Trying to think of other questions. Is there anything you would like to bring up?
Yeah, I'd tell you more about myself. As I got older, my practice got older, and I found myself caring for older patients. Became interested in geriatrics, and went down, took the exam to be certified by the American Board, to be certified with additional qualifications in geriatric medicine. There's no board of geriatrics, it's the American Board of Internal Medicine. And I went down with 7 or 8 other doctors from St. Vincent Hospital to take the examination. And while we were sitting around a large table having coffee, one of the doctors said, "It's no fair you're taking this exam." I said, "What do you mean it's no fair?" He said, "Well, when they ask questions about normal aging, you just got to think about yourself."
So you cared for older population as you grew older yourself?
Right, and I became coordinator of geriatrics education at St. Vincent.
And what were your responsibilities, and what did you do in that role?
Well, there was no geriatric education as recently as 10 years ago. And it's an essential because of the demographics. The population is aging. The fastest growing part of our population is 85 or over. And it became essential to make people aware that older people might be different. I think there are a number of things that I would change about geriatrics. To start with, I would not have old people taken care of exclusively by geriatricians. I think that's the family doctor's role and the internist's role. And in the first place, it's impossible. There'll never be enough geriatricians trained. But I don't think it's desirable, even if we could. I think that the same person that takes care of a 48-year-old ought to be able to take care of an 88-year-old. Although recognizing differences in the practice of medicine and in response to treatment and so forth. And I became very interested in that, set up a program so that we had 1 or 2 residents rotate for a month through a geriatric service, partly based in a nursing home, partly based in outpatient facilities, clinics around Worcester and so forth, and did a lot of clinical teaching in geriatrics. Had great support. There were some 20 St. Vincent doctors who were certified for added qualifications in geriatrics. That's more than were even certified in internal medicine when I started practice. And all of whom were cooperative and very helpful with the program. The program continues now with much greater rapport with the university, with Memorial University program in geriatrics under Dr. McGee. Dr. Finale he's now a national officer with the American Geriatric Society. And we do have some cooperation between the 2 programs. And I still, as I mentioned before we started, I still spend 1 morning a week in teaching with that, although I'm otherwise totally retired from medicine.
Is this something that's required for residents to take part in, geriatric
Yes. At St. Vincent's it is. I presume it is here.
Yeah.
It ought to be.
I agree. Okay, is there anything else you'd like to share? I know we're starting to run pretty short. I think we have another 5 minutes. If you...
No, I'd be glad to tell you anything that I can, anything you'd like to know. We haven't touched on sociologic changes that have affected medicine, and they have been enormous. We spoke to some degree about financial changes, but there's an enormous number of other changes based on the way our society has changed from in the last 50 years, and it has changed considerably. And that's one of the joys, incidentally, of geriatrics. When I would have a 20-year-old patient would show up in shorts, T-shirt, sandals. Older people, when they go to the doctor, get dressed up. They'll put on a clean shirt, and women often wearing hat and gloves even, which is ancient history nowadays. And I presume in the next few years will be totally gone.
Yeah.
But the attitude toward physicians has changed considerably.
Yeah. How do you think that affects the practitioner's ability to treat the patient?
I hope it doesn't affect the practitioners, but I think it can't help but do that. And I think even more important as a matter that affects doctor-patient relations is the threat of malpractice. This was non-existent when I was a young doctor. And now it's something doctors think about every time they write a prescription, every time they make a suggestion. We know what can go wrong and how can I be blamed for what goes wrong. Not a good attitude for a doctor to have. He and his patient ought to be one of complete mutual trust. And I don't feel it is as it was 50 years ago.
Yeah. Do you think there's anything that can be done to rectify that problem?
I don't have an answer in a minute or two for that. I was a supporter of the Medical Society's 10-point program from the late 1970s when this began to become a problem. And I don't see anything good in going through all 10 points, which I probably can't remember anyway. But there are things that can be done. Initially, I certainly would want to reform the contingent fees that lawyers get. I read recently that 60% of all monies paid into malpractice premiums go to a lawyer, finally at the end. I think that's horrible. It ought to go to the patient if there is indeed malpractice. And I think that's where I would start reform.
And I guess along the same lines, do you think the threat of malpractice lawsuits makes it very difficult for a physician to apologize when something does go wrong or does go out of control?
And I really don't think so. I think that depends on the physician and how his parents raised them. I think there are all kinds of physicians. There are nice ones and not so nice ones. But I would think that when things go wrong, you ought to explain how things went wrong. And hiding things is a guarantee you're going to get sued. I think patients understand, most patients understand the doctor is human and things do go wrong. I think they should be brought out and into the light.
Okay. I think we touched on quite a bit.
I enjoyed talking about it and enjoyed remembering these things.
Enjoyed talking to you. You're a very good storyteller.
Yeah.
Interested? I didn't even look.
You should hear me at a cocktail party.
All right. Well, thanks for joining us.
Thank you very much.